Right, shall we get started? Welcome everyone to our improvement forum. We do expect that we'll have a few less people than we normally do in the forum, given the operational challenges. But for the last few of these that we've recorded and published online, we've had quite a lot of views afterwards. So we decided we would go ahead and hopefully staff who can't access it right now will be able to look back and see some of the improvements when they have got a little bit more space. For anyone who doesn't know me, my name is Maria Riley. I have the pleasure of leading the Royal Academy of Improvement. Just in terms of the meeting etiquette, so if I could ask you to stay on mute if you're not speaking. We will take hands up to get questions, or please feel free to comment in the chat as people are presenting things to you. So we follow a kind of an agenda really focused on some of the improvement presentations, people coming to talk about the improvement that's been happening across the trust and that they've been leading. So today we've got a bit of a cancer focus in that spotlight bit, with Nina Morgan, our cancer manager, talking to us about cancer pathway navigators, Nabil Ghafour about the 28-day faster diagnosis project, and then Richard Grattan's going to talk to us and show you a video about Attend Anywhere, our video appointments platform. I don't believe Stacey's joining us today, our improvement facilitator, Stacey Burton. She's supporting the vaccine programme at the minute. I'll tell you a little bit about the training offer coming forwards, and then we'll finish by sharing and celebrating some of our success, some of the small improvement successes, awards that we've won across the trust. So if we get started, I think we're with Nina first to talk to us about the cancer pathway navigators.
Thanks, Maria. So, as part of our Cancer Alliance funding, we were granted some roles for 3 whole-time equivalents for some cancer pathway navigators. So, for those of you that don't know, as part of the cancer agenda, we're expected to deliver cancer pathways under the rapid diagnostic concept by 2024. And it was identified that key roles to support the delivery of that were cancer pathway navigators. So we were granted some funding, and we started to look at the roles that were already existing within the organisation. So at the time, we had cancer support workers. So you can see on the table in front of you the difference between the 2 roles. Then we started to look at what the cancer pathway navigator would be supporting, so assisting in a coordinated and smooth, efficient service for patients, being able to escalate the issues to ASMs, identifying barriers of care and escalating to the relevant team members, ensuring tests and procedures and appointments were scheduled in a timely manner, and again the daily navigation of targets patients throughout the pathway. Initially, the roles were placed within the care units, but then we decided to change the structure to achieve a more consistent approach to the roles and build the resilience within the team of the 3. So we went away and looked at the regional differences across both networks, so across the East Midlands footprint as well as the South Yorkshire footprint, to get the feedback from how those trusts that had these roles already in place, how they felt supported cancer services. A lot of the feedback was around placing them centrally within the cancer centre would enable that cohesive working. So the 3 posts were put in, and the allocation that we agreed was based on patient numbers. So you can see 1 post manages the urology, gynae, breast and haematology pathways, 1 manages the lower GI, upper GI, unknown primary, endoscopy and head and neck pathways, and then the other one supports the lung, skin, imaging and vague symptoms pathways. We identified some objectives for the role, so improving patient experience and pathways, so that was assisting in the monitoring of patient appointments and investigations, helping to remove barriers and meet patient needs by ensuring that patients are diagnosed within the 28-day standard. Identifying new ways of working and building relationships within the care units. So the roles were put in to complement and support all areas by bridging the gaps between corporate cancer services and the care units. They're also there to help identify concerns and escalate where necessary to appropriate people within the multidisciplinary teams that we work with in cancer services. Managing expectations to deliver best possible services, so being flexible in our working, supporting services to ensure it's the best patient-focused care that we can give. And then finally, aligning services by sharing best practice, so encouraging engagement for a shared purpose, improving education around cancer standards, and identifying ways to implement change and share best practice across all our care units within the organisation. So this is a case study based on how our navigators have been supporting patients. So you can see here we've got this example is around a patient that came in for an imaging investigation. Not wanting to attend because they're a vulnerable person and having concerns. The reason that the patient hadn't been given an appointment was down to patient choice, because they wanted to remain on the waiting list because they felt uncomfortable at the time to attend. One of our navigators was able to telephone the patient and spend time talking through the concerns with the patient and informed of the precautionary measures that we were taking, which then later resulted in the patient being reassured and felt able to attend his appointment. This slide is just based on some of the feedback that we've had from the care unit team, so how they've really felt that it's been extremely effective in terms of the reduction of time spent chasing clinicians and supporting patients as much as possible. And then you can just see here, so this is just a snapshot of some of the measures that we monitor in cancer. So the top left-hand graph is patients over 104 days that are waiting in our system. So you can see the peak was during the first wave of COVID. We had 131 patients over 104 days in the system. The top right-hand graph is the patients on our PTL. So our PTL is our patient tracking list. So that's an entire list of everybody that is referred in for a suspected cancer referral, broken down in the time band, so you can see the green and the red. The bottom left-hand graph is patients over 62 days on our PTLs. Again, at the peak during COVID, there was 250 patients. And then finally, on the right-hand side, bottom right-hand side, is the faster diagnosis performance, which Nabil's going to talk through a little bit more in the next presentation. But you can see from when the navigators were in post, we managed to sustain a improved performance. And that's that. Any questions?
Thank you, Nina. I think we were so lucky to get the funding for these posts, weren't we? And it's an area where the post has changed significantly from where we first started. We thought long and hard about how these roles were going to work, how we were going to fit them into the existing structures with the operational teams and make that work. And we were kind of a little bit unclear whether they would have the impact that we hoped for, particularly in terms of that patient contact, but they've definitely proved to be absolutely vital roles, haven't they, in terms of supporting us. And you can, I mean, it's early days, but you can really start to see that both in the feedback from patients and the staff in the trust, but also in terms of that performance, as Nabil will take us through a little bit further detail. Are there any more questions for Nina? Any comments, questions? Helen, did you want to come in?
Yeah, thank you very much for that presentation, Nina. I thought it was magnificent. I'm still slightly confused as to the extent of the focus of the role and making sure that everything's working really well behind the scenes, and that we're keeping an eye on who's on what bit of the pathway and how they're accessing service. So it's I don't mean this pejoratively, a back office facilitation role, and the extent to which it's a patient-facing role, kind of advocating on behalf of the patient back in to join up all those services, or perhaps it's a bit of both, but a flavour of all of that would be interesting, please.
So it is a bit of both. So a lot of work is done behind the scenes in terms of ensuring that we're booking patients in as soon as possible, really, because we have found with some pathways that we're not always seen to be as proactive as possible. So actually these roles have supported that by looking at a patient by patient basis. But in terms of the patient facing aspect, if a patient along their pathway is found to have any concerns, or if a patient's identified to. So sometimes we have patients that want to go away and have thinking time, and it's just having that point of contact with the patient to say, you know, is there anything that we can support you with in order for you to make that decision? And also we're looking at how, in terms of the development of the role and the patient facing side of it, we are looking at, particularly with the second wave of COVID, how these roles can support patients that may be potentially feeling concerned about coming into the organisation, how we can make sure that we can use them as like a touch point almost for us to touch base with the patient, to make sure that those that are on the long waiting pathways do continually have that contact with the organisation throughout their waits. Does that kind of clarify things a little bit?
Yes, that's super. And if I was to wander through the Macmillan Centre in the way that we used to be able to wander through the Macmillan Centre and asked half a dozen patients at random, had they heard the role, would you expect people to have heard the role, or would it be more on a case-by-case basis where you needed to make a particular intervention because of the nature of that patient's journey?
I think it would be a patient-by-patient basis. I don't think we've not kind of put it in as, we've kind of put it in to manage the barriers, and we know that actually operationally the barriers sit within the operational side of it rather than the patient facing side of it. So I think it is very much patient by patient basis.
Well done. Excellent work.
Thank you.
Thanks, Helen. I think given what you've described, it is a role that we really challenged our thinking on in terms of getting it right, not taking the ownership of the operational management away from the service managers. How was this going to fit? And it's almost, it's kind of worked better than we thought it would have done, hasn't it, Nina? And being that interactive person, it's the person who's got the space to go and see the consultant secretary and make an appointment happen, or make that phone call to the patient and reassure them about coming in. All that kind of, it's the added space that the service managers just operationally don't have, and that's how the role has really been beneficial. In an ideal world, and patients on the smoothest pathway don't need this role, and you know it works perfectly. But we don't live in an ideal world, do we? We kind of have that constant operational challenge, and this is what these roles have really targeted and enabled us to act upon. Any more comments for Nina, questions, or shall we move on to Nabil? No, we'll move on. So Nabil, this is a very much linked project. Nabil, if you talk us through your 28-day faster diagnosis project and where you've got to.
Hello everybody, my name is Nabil. I'm the 28-day faster diagnosis standard project lead. So I'm just going to give you a quick overview of my project that's been going on for just over a year. So for those, first of all, who don't know what the 28-day faster diagnosis standard is, I may refer it as 28-day FDS. It's a national cancer standard that aims to ensure all patients who are referred for the investigation of suspected cancer find out within 28 days if they do or if they don't have a cancer diagnosis. 3 key aims: reducing anxiety for patients, improving the clinical outcomes. So for those patients who do have a cancer diagnosis, finding the cancer sooner just improves the pathway and the clinical outcomes, and just reducing variation across trusts in the UK. So where patients may be coming from Derby, Sheffield, everywhere, they should all be going to the same standard. And if you want to know more information about it, it's all on our Cancer Internet. Just a quick project summary. So I started in this role in September 2019. And the project went up to just the end of last year, so just over a year, and it was extended due to COVID-19. We had 3 key aims. So one was to complete an awareness campaign before the national launch of the standard. The second one was to improve the non-cancer patients' performance. So non-cancer patients was key. So the majority of the patients that are referred on a cancer pathway are non-cancer patients. And sometimes some of their pathways can be slower because they're seen as non-cancer patients, but they should still be held to that same standard as all of the other patients. And the final one was just to implement administrative admin improvements, again for non-cancer patients, because sometimes their pathways can lag due to them being non-cancer patients. So 3 key focuses was the comms engagement, non-cancer patients, and the admin improvements. So this slide is just a project timeline of my project over the last year and a half. So this timeline on the left, key improvements, and I have been quite fortunate to work quite closely with the Royal Academy. So I've had a lot of support from Maria, Sean Sumner, Pam Rumble on how to utilize CUSA tools on the project that I did. So for the first part of my project, just before COVID, we just identified the key aims, milestones, and our improvement focuses. And in this part of the project, I used a lot of CUSA tools just to start my project, get my aims correct, identify all the key stakeholders, data collection, identifying what areas to improve on. There was a lot of communications work that I did. So if you can just see on the right-hand side where it says CUSA tools utilized, you'll see in this part of my project, I utilized a lot of tools for the improvement focus, which is just in the middle part of the slide. Then the second part of my project was a little bit more tricky, as there have been a lot of things. So from April to December, COVID had a massive impact on the standard due to diagnostics being on hold, so CT scans, endoscopies. There was also a delay to the standard being launched. We still didn't focus on some of our long-term improvements, sort of IT improvements and admin improvements. And I also focused on handing over to the cancer pathway navigators that Nina touched on. And in this part of my project, it was sort of towards the latter end. So it was about supporting people through change, identifying if it was sustainable and sustaining momentum as well. And this project management overview as well. Next slide, please. I just want to quickly touch on the tools that I utilized for this project that will just show the improvements in the next few slides. So first of all, my project milestone, I had a lot of support from Sean Sumner, Pam, on identifying all of the key improvements and how to keep on track of them. And it's a good way to keep accountability of your project as well, and having the oversight from senior managers as well. I found stakeholder analysis very good. I was new to the trust, finding out who, what, where, and when. And that was a key part of me getting to learn the trust and people within the trust. Communications, I think, is very important on any project, particularly with this one. So it's a new cancer standard. So I did a lot of comms engagement with all of the stakeholders across the trust that would be involved within this standard. To manage performance, SPC charts are something that's highly recommended as part of CUSA and NHS improvement. So they're a very key thing to identify whether we're on the right track or whether we're falling behind. I did a lot of process mapping with administrators, service managers, assistant service managers, really trying to identify where we could improve those non-cancer patients' performance. And on the latter part of my project, just towards the end, we did a lot of sustainability modeling. So trying to identify how to hand over to the cancer pathway navigators and the assistant service managers. So a combination of all of these have culminated in the next two slides, which is the performance. So first of all, this is our overall 28-day FDS performance from May 2019 to October 2020. So from where we initially started collecting data in May to September, we were just at the beginning part of just collecting data and identifying where the standard was going to go. The key improvements that I worked on were from September to December. So you can see that from those 3 months, we saw a massive jump in performance. Going into 2020, we were still trying to find our feet on improvements, and there was other reasons that delayed, impacted performance. And obviously COVID has had an impact on performance, but I just want to touch back onto Nina's cancer pathway navigators, that they have had a massive impact on 28-day FDS standard. So one of the achievements that we've had with this project is, prior to the cancer pathway navigator starting, I did a lot of comms and engagement with clinicians just to introduce them to the standard. So when the cancer pathway navigators came into their role, they were able to approach clinicians and administrators and just say to them about the cancer standard, and they didn't have to reapproach them about what it is and what it means. So they were able to go about their role, hopefully a lot smoother. The second slide, performance slide that I've just got here, is touching back on one of my key aims, which was the non-cancer patients. So as I mentioned, non-cancer patients make up a large bulk of the patients that are referred on a cancer pathway. So it was key for us to improve the performance on these patients. So I'm really proud of the performance that we had from September up to around about February on these blue marks. And it just shows the potential that we've got when all of the pieces come together, that we really are able to get these patients through our pathways very, very smoothly and very quickly. Again, obviously, COVID has had a massive impact on performance after April, May onwards. But for the future, I do believe the cancer pathway navigators will have an impact on this performance, and we'll sort of see it go up into the high 80s again. Just the final slide in terms of what did we achieve. Some of the key achievements I believe for this project, just reflecting on it as part of my evaluation. So we did improve the 28-day FDS awareness across the trust. So clinicians, administrators, service managers are all aware of what the standard is. We saw a massive improvement on the non-cancer patients prior to COVID, and I do believe in the future that will continue once some of the challenges of COVID do pass. One of the key performances that I think I'm really proud on that, look back on that, I think hopefully a benchmark for the future is our Q3 performance that I showed in the previous performance slides. There's still continuous administrative improvement. So although I finished the project, I've handed over the process maps to service managers to continue that improvement. We saw a reduction in the admin delays and also done a successful handover. Just one final thing that I just wanted to reflect on. So I've done this project for a year myself, and as I mentioned, I've had support from the Royal Academy. And these are just my reflections that I hope other people that are either doing projects or are looking to do projects in the future. So I would definitely recommend speaking to people within the Royal Academy for support. So Pam, Sean, Luke did a lot. I remember Luke did a masterclass for us on SBC charts. So if you are doing a project, email them or speak to them. They're very, very helpful. Comms and engagement, don't underestimate the importance of this. For me, it was key going around and speaking to people and getting to know people and just speaking to people. Obviously, I know now times are different, so do it on MS Teams. Active listening was important for me, and also getting my elevator pitch right. So if you had 10 seconds with a clinician, how would you present your project to them? That kind of links to stakeholder analysis. So I managed to identify the key influencers within my first 6 months as well. And finally, just utilize any CUSA tools that are available. If you haven't been onto the CUSA course, go onto it. Speak to people from the Royal Academy to get support on the tools as well. Then that's sort of a reflection of my project for the last year and a half. Thank you. Any questions?
Thank you, Nabil. Really interesting reflections, and I think will be really valuable for people. I think it is worth noting that the Trust was actually a pilot site for this standard. So as a national standard, it was only introduced as a mandatory standard across the NHS in April this year. We are one of the few trusts who were a pilot site, and we took the opportunity of getting funding and support for Nabil's role to really work on that improvement early. So we've placed ourselves really well, even though our performance is not currently where we would like it to be. We've done that early improvement work, which will support us in terms of when things does go back to normal, in delivering sustainable improvement. And if you also look at this standard externally, despite all the challenges, we're actually doing a much better than a lot of trusts have, which is reflective of the early project work and the huge effort Nabil and the clinicians and the service managers have put into to the change that has enabled that improvement. Any questions or comments for Nabil? Luke, did you want to come in?
Hello, yeah, and just to check, can you hear me? I just want to check my microphone before I start speaking.
Yes, we can.
Yeah, brilliant. I know I've had some issues in the past on this forum. So really, it was just a comment just about how that presentation was really useful to see how you'd use the CUSA tools to influence kind of all your work, Nabil. And I think that just kind of showcases how useful the course is. And hopefully some of the other people on the call who are going to watch it after can see how CUSA could benefit them. So brilliant. Thank you, Nabil.
Thank you, Luke. Mr. Amanath, did you want to come in?
Yeah, thank you. It's nice to, I'm a clinician, I'm a colorectal surgeon. It's nice to see that you got so much resources put into the 28-day pathway and monitoring and achieving the results and telling people that they don't have cancer who need to be told. But who is helping the people who are on the routine pathway and who don't get onto your 28-day pathway till they're diagnosed to have cancer? Who is making sure that their diagnosis of cancer is done in a timely way and they are not shunted out of the investigation pathway because of 28-day referral patients taking priority? Because obviously we have limited resources.
Yeah, Nina, did you want to answer that one?
Yeah, I was going to say, do you want me to answer that one?
Yes.
So, Mr. Ramanath, just so you're aware, there's obviously the consultant upgrade pathway. So any patient that you are found to have a high suspicion of cancer can be upgraded onto a 62-day pathway, which is something that obviously we should encourage. We are trying to encourage clinicians to do. So they are identified as being cancers, and even if they're not on a cancer pathway, because they are confirmed cancers, they are still prioritised. I don't want you to think that they're not prioritised, because if anything, obviously they are more clinically urgent than those patients that we're waiting for the diagnosis of. Does that help?
Yeah, but as you know, in some specialties, it's very difficult to really decide if they have a high index of suspicion of cancer or not. So even the routine investigations need to be done in a timely manner. And that's what I worry about.
Right, so you just mean routine pathways in general?
Yeah.
I suppose that's a difficult one to answer, because unless they're identified to have the high suspicion, there isn't a safety net in place, if that makes sense. From a cancer team perspective, we're obviously only focusing on those that have got the high suspicion.
So if I try and help Nina, I think it's something that we're acutely aware of in terms of the current COVID situation, and the fact that patients may be referred in for a routine endoscopy, and that may find things that we weren't expecting. So we're very aware of that identification within the routine, and how we can try and manage our capacity to make sure that we continue to support those patients and identify the things that we weren't expecting to be a cancer. I think at the start of COVID, we introduced a number of things with trying to triage patients, so that if clinicians felt that a referral in was particularly worrying, that we could prioritise that patient, whether they were on a routine or an urgent pathway. And the new referral assessment service, the RAS service that we've implemented as well. One of the things that we're hoping out of that is that, because the clinicians can choose whether that's a referral, that referral should go straight to test, whether it should be advice and guidance to the GP, or whether that patient needs to be seen in either a telephone, video or face-to-face clinic, that will support clinicians to early identify at the very first stages of the referral coming in from primary care, whether that's a patient that actually they're really worried about and would like to kind of see urgently, or to fast track through a diagnostic test. So that's one of the aims of that RAS. What we're currently doing, so that referral assessment service has been in place since the 1st of September, and for people who aren't aware, what that means is when you go to your GP and you do choose and book, and GPs would have ordinarily booked a patient into a slot, that no longer happens. The referral comes into us in secondary care, the consultants review that referral and decide on the most appropriate next step for the patient. So as I say, one of the benefits that we're hoping to see out of that is that patients have their first step in secondary care as a value added step, either as a diagnostic or as the right method of appointment. We are currently looking at the data and evaluating that, so we hope to be able to very soon demonstrate what impact that's had on referrals, how many patients were deemed not to need to come into secondary care, or how many went straight to test, or how many went into different forums of appointments. So we'll bring that back hopefully through a future improvement forum.
Thank you.
Thank you. Any more comments or questions? No, should we move on to Richard then? Are you going to talk to us about Attend Anywhere for video consultations?
Yeah, sure. So Hello everyone. Obviously quite a few of you have heard me talk about video appointments previously, but for those of you who haven't, I suppose I'll just give a brief summary of where we are in the trust and the background of this really. So before we knew anything about coronavirus, the trust was one of 10 national pilot sites in England for using video appointments. There's a number of different platforms available, but the one which is being promoted heavily across secondary care is NHS Attend Anywhere, which is the platform that we use. So before coronavirus happened, we had started a very successful pilot in one of the women's health physio services, and it was receiving really good feedback from clinicians and from patients. And we were just about in a position where we were going to expand it across some other therapy services. Then obviously coronavirus happened and the world changed, and we were faced with a different position where obviously lots of patients were unable to come into the hospital for their usual face-to-face appointment. So since last April really, we've been working really hard to make video appointments available to ultimately to all clinicians that offer an outpatient appointment. What the project isn't about is trying to force patients or clinicians to conduct video appointments, because clearly they're not always appropriate or possible. But what we do know increasingly from evidence from where video has been used before and our own feedback now, which is almost a year old, is that it's an extremely positive and popular method of appointment, particularly for patients. The latest data we've got is overwhelmingly positive from patients. So 97% of all the patients that have ever had a video appointment have said that it meets the needs, the care needs that they expected from the appointment. So it's really reassuring what we're seeing. We're now in a position where the vast majority of major services and specialties in the trust are set up, some more recently than others, and we've seen in many instances complete changes of practice. So areas such as CAMS and children's speech and language therapy services use video extensively, and if you were to go back only a year, obviously these services weren't conducting video appointments at all. So there's been a complete shift in thinking and practice, both from clinicians and patient expectations. CAMS in particular are using video appointments more than everybody else. Their acceleration from no video appointments to today's position is massive. Prior to Christmas, we had increased to around 200 video appointments per week across the trust, and we're expecting that going into this year, that's sustained and probably increased as more services get to use the platform. So what we've done here, and we'll show you the video in a minute, is we've done a short video, and this is one of hopefully two videos, one we're going to show today, the other isn't yet available, and we've asked a number of our clinicians to talk about their experience of using video appointments and how it's been a positive improvement for them under coronavirus conditions, but also for the patients that they've seen. The second video, which is going to come along hopefully in the next few weeks, is going to be a patient experience video. We have one of the patients I've just watched it today actually, and they were extremely positive about their experience. So I think the video is about 6 minutes long. If you want to watch that, and then when the video is done, ask me any questions you like on video appointments, that'd be great. Thank you.
Hello, my name is Richard Grattan and I'm part of the Royal Academy of Improvement at Chesterfield Royal Hospital, and I'm supporting an exciting project which is enabling clinicians to offer video appointments to patients when it's clinically appropriate. We were an early adopter of a system called NHS Attend Anywhere, which is a system that's now used widely across the country with positive feedback from staff and patients. As a result of this, before the onset of COVID-19, we started offering some appointments to our patients by video, and we had been in the process of expanding the pilot. However, our response to the pandemic changed our planning. We'd felt that more services might be able to offer video appointments, and we're now working towards where all clinicians are going to be able to offer this type of appointment to patients whenever it's appropriate. The appointments work in exactly the same way as a face-to-face appointment, but because it uses a video link, these patients do not need to visit the hospital. Here are some of our clinicians to explain a bit more.
Hello, my name is Dr. Richard Jennifer, consultant geriatrician and physician at Chesterfield Royal Hospital. When COVID-19 came to the UK, we were forced to find different ways to support patients. Suddenly it wasn't always safe or appropriate to see everyone face to face. We have been able to make good use of telephone clinics, but there are some situations when you really need to see someone to understand what is happening. Video consultations make this possible. Recently, I reviewed a patient by video who had developed a tremor and was worried that it might be Parkinson's. I was able to carry out a number of assessments, including looking at the way the patient moved. They were able to even show me samples of drawing and writing. They were so relieved when I told them that I couldn't see any signs of Parkinson's. We talked about what I thought was causing them to shake and agreed a plan. All of this was done without the patient needing to leave their home. It was important that they trusted me. I feel that being able to see each other's faces helped with that, because communication is about so much more than what we say. Video clinics allow us to support patients in ways that we didn't think possible just a short time ago. They help us to make better connections with the people we see. They also make it possible to create a safer environment for anyone that needs a face-to-face assessment.
Hello, my name is Jules Ward. I'm a specialist support worker with the Learning Disability Child and Adolescent Mental Health Service, LD CAMS. Usually our team does a lot of community and home visits, but during the pandemic we've been offering video calls to the young people and families that access our service. We provide support in many different ways. Video sessions allow us to continue to do this. For instance, I offer relaxation sessions, yoga and deep breathing techniques. I also do a lot of educational sessions. We also offer observations over video, and these work really well. As we're not physically present, we're not changing the dynamics within the environment. This can help us to have a better understanding of current needs, effects of medication, changes in behaviour, emotional well-being, and so on. It's so important for young people to be able to see us, not just to hear us. Many of the young people we work with have communication difficulties. Some may use Makaton Sign Language, and we wouldn't be able to communicate over the telephone. Being able to see each other's faces, hands and bodies is really important. I find that young people and families often appear more relaxed or less anxious during our video sessions. They've not had to travel or rush anywhere for our appointment. Using video calls is helping us to be innovative, but most importantly, it's helping us to continue to support the young people and families that access our service.
Hello, my name is Dr. David Brooks. I have also found video clinics a useful addition to my consulting toolbox, particularly when dealing with emotionally laden conversations. Perhaps the best example from my practice was a gentleman who was staying with his sister, having returned from working overseas just before lockdown started. He had planned to move to London to stay with his son while looking for a house, but found himself stuck in Derbyshire due to the movement restrictions. He began to lose weight unexpectedly, and when found to have suspected metastatic disease on a scan, was referred to my Cancer of Unknown primary clinic. We organised a biopsy. A few days before the biopsy was due, restrictions were lifted. We decided that he would go ahead with the biopsy and move to his son's the next day. A week later, we had a video consultation where I was able to see not only him, but his wife, his son and daughter-in-law. And while discussing his cancer diagnosis, the palliative nature of any treatment, and his limited prognosis, it was so helpful to be able to see how my words were landing on each of their faces, so I could better pace my communication. And it was particularly beneficial to him that he could do it all from the comfort of his son's home in London.
So as I hope you've seen, video appointments give us a real opportunity to improve our services for patients. 92% of patients have reported their experience as being either very good or good. And them not having to come into hospital is saving them time and money. It's reducing unnecessary travel, parking charges, and them having to take time off work. An increasing number of services are now able to offer these kind of appointments, including specialties such as CAMS, children's speech and language therapy, physiotherapy, respiratory and head and neck services. And we're soon going to be expanding this to other areas including cardiology, trauma orthopaedics, breast and our preoperative assessment service. You can find out more information about this project on the Royal staff and public websites, But if you've got any questions, please contact me at the Royal Academy of Improvement.
Thank you, Richard. That video gets me every time. It's kind of so powerful in terms of the stories from the clinicians about the patient's experience and how valuable it's been for them. So it'll be really great to see the subsequent video, which is all focused on the patients. But my huge thanks to you and to all the clinicians that were involved in putting that together, because I think it's a really great video and quite thought-provoking in terms of the patient experience. And how that can be improved from a video consultation rather than just a telephone consultation. Are there any questions or thoughts for Richard?
Oh, God.
Helen, did you want to come in?
Hi, I just wanted to come in quickly and say hi to Richard, and I work in CAMS, and I'm also one of the clinicians using it, and it's been really, really positive, and I think it's great to see that video, Richard. And I suppose I just wanted, I'll make a separate contact with you, Richard, just about it, but I think just to add that a lot of us are using specific clinical therapies very effectively through Attend Anywhere as well in CAMS, so things like cognitive behaviour therapy, and it's really been incredibly helpful, and it's really interesting to see how much our use has accelerated, Richard, in that time frame.
Thanks, Helen, and yeah, good to put a face to a name, really. I think I'd echo what you're saying. I think when we started off with video appointments, I think it's really easy to kind of look at the obvious things and just look at the appointments where you're just having an ordinary conversation with a patient. But I think what's become really obvious in the last really a year is how many different uses there are for video. And the examples you've given are great, and you can see in the video that Jules is doing various types of therapy in the video. David Brooks's example from palliative care is a great one. One of the best examples, which happened quite early on, was a patient with diabetes, and they were at home and they fitted an insulin pump with direction from a specialist nurse and a rep. And these are the sorts of things that, you know, a year ago we never ever would have thought we would be doing. And it's not that we're saying that all appointments can now be done by video, because clearly some things are just not appropriate and they're never going to be. But I think the idea of thinking a little bit differently in the way that you've suggested is really important. There's lots of uses for video across all services, in my opinion.
No, that's great. And I'll make a link with you, Richard, as well, because we've done a CBT service evaluation in the service, which looked at the feasibility of remote therapy. And I don't know if that's come to your attention, so I will link with you outside of here.
It hasn't, but that'd be great to hear.
Great.
Every example's good. Thank you, Helen.
All right, thank you.
Thanks both. Louise, you'd got your hand up. Do you want to come in?
I did, and then I put it back down again. But I was just wondering, are there any particular barriers you're finding at the moment to extend this further to clinics that could use them that currently aren't?
I don't know if there's any specific barriers, Louise. I think one of the challenges we've got, definitely, when we're trying to roll out something as quickly as this, and I keep saying the same thing, but a year ago the Trust had never done a video appointment with any patient on a formal basis. So we've had such a rapid improvement and change that clearly some patients and clinicians will be nervous about this and wondering whether it's appropriate. I suppose the only thing that I would say is that the evidence now is stronger and stronger, that once we start using these things, it becomes easier and easier to do it. The system itself is dead easy to use. I think we've got, I don't know, maybe 500 users, and very few of them have ever had a demonstration because the system's so intuitive. And as you've heard me say in Helen Castle, there's so many different uses for video that I really think it's a question of thinking slightly differently. And any patient that we're offering a telephone appointment for example, if it's possible for the patient, that could be done by video, and you could make a strong argument that it would automatically be better because you can see the patient.
Yeah, I agree. And are we sort of, for those areas that are sort of reticent, are we hooking them up with the people who are using it and found it easy so they can give them reassurance?
Yeah, and I think that's the next stage of the project. So now we've got an evidence base where a number of services are using it widely. It's easier to link services together. And one of the other things that we're doing is we're also looking at other sites. So we're looking at what Derby are doing, for example, and certain services which are using video more at Derby than they are here. We're now trying to link clinicians to sort of share experiences.
Cool. Thank you.
Thank you.
Thanks both. I think that was kind of the driver, wasn't it, really, for that video, Richard, and for the subsequent one about our patients. They're intended to be thought-provoking videos that encourage some of the services that haven't necessarily engaged yet to understand what the benefits can be for our patients and the clinicians themselves. Claire Bond, you had your hand up. Did you want to come in?
Well, can you hear me?
Yes,
hello?
you can.
You can. So I think sort of Richard sort of covered it in his explanation, but I do think he's right in that sometimes it's about changing mindsets, because I know in the past I've worked with a variety of different specialties and specialist nurses, and I think that there's always this sort of temptation to say we have to see them face to face because we're giving bad news, or the CNS needs to see them. And actually I think in the current climate that we've got, where you can't bring somebody into the hospital for an outpatient appointment with you, they're probably more supported at home. And have we considered multiple conversations? So where I can think of one of the clinics where, they might need to come in particular, but other times where we say, well, the consultant's going to ring you, and if they do give bad news, and you would normally at that point go and have a chat with the CNS, why can't this, and it might be happening, do the CNSs not then, be able to call back from a different area and have that conversation over the phone? Because I think if I was coming in to have bad news, I was thinking throughout what you were saying and the presentations, I think I'd rather be told over the phone. I don't need you to tell me face to face. You can see my reaction, but my family could be there at my choice to support me. When I come into hospital, sit in a clinic, you might be thinking you're doing the right thing for me, but I can assure you, I don't think you would be. I think I'd get more support doing it that way. And I was just sort of, thinking how fantastic. I know it's not possible. Sometimes we have to do physical examinations and tests, but I think it really is. Have we got any feedback from patients? Is that what you said is coming in the other video?
So every time there's a video appointment, every time a video appointment happens, Claire, there's a survey that pops up on the screen for both the clinician and the patient. Okay. So we've got loads of feedback, as you can imagine now. And I mean, I can't share it now, but I can share the patient feedback and the staff. The patient feedback is amazingly positive. There's so few negative comments. It's brilliant. And your example about breaking bad news, there is an evidence base that's getting stronger and stronger now, that actually a lot of patients would prefer to be given bad news whilst they're at home and not come to hospital.
Well, the thing is, we give them bad news, we kick them out of the room, they're feeling all flustered, we're expecting them to get on public transport or drive home when they've probably been told the most devastating news of their life. And we think that we're doing the right thing for the patients because we've brought them in and told them and sat them in front of us. To me, the whole process is so nerve-wracking. I'm fortunate not to have been in that position, but if I was at home, I could think, right, my family's here, they can make me a cup of tea, I've not got to rush out, I've not got to gather my thoughts and drive myself home. I think we need to desperately challenge some of these attitudes where people feel that it's kinder to bring them in and do it in person, because I feel very strongly that we are only considering what is historical and we felt was best in the past, and we're in new times now.
I agree, Claire. It's the same with a lot of things, isn't it? A lot of this is learning and understanding what works best. And video is something that is very, well, it's less new than it was, but it's relatively new for us. And we just need feedback from clinicians and patients and that sort of momentum, if you like. And some patients will want to come to hospital, and that's appropriate. The other thing about NHS Attend anyway, and I won't go on much further, but when you talk about different people, you can have up to 6 different people on the same conversation. So in theory, you can have a patient and their relatives in different spaces and the clinician, and we are doing that in some instances.
That's really creative. That's really good. Thank you, Richard.
No problem.
Thanks both. Claire, we are acutely aware of that that position across the cancer patients and being able to offer that breaking bad news conversation for a better environment for the patients if they choose to. Pamela, you've got your hand up. Are you going to talk about that point where we've been thinking through the tumour sites and how we can offer that?
Hi, Maria. Yes, I know Cherie's been linking in with the divisional teams to help us better understand where we're able to offer all 3 options for breaking bad news, whether it's phone or video or face-to-face based on patient's preference. But I got my hand up to thank Richard just to say the video was absolutely fantastic. It was really powerful. And to ask you thoughts about how we can share this with our colleagues in primary care as well, so that they're aware. So almost upstream, as GPs or primary care clinicians are talking to their patients, they're letting them know that there might be alternative ways for their care to be delivered as part of their pathway. Is that something we're already sharing with primary care? Could we share the video?
I think it's something we can do more of, to be perfectly honest, Pam. I mean, the video is on our intranet, and it's also on the internet as well, so it's a public video. But I think some way of directly sharing this with primary care would make a lot of sense, because if patients are aware that this is the type of appointment that might be offered or could be offered, that'd be really powerful.
Thank you.
Thanks both. I think one of the things we've been working with primary care on is that messaging. So when I talked about the referral assessment service earlier, what we want GPs to do is have a conversation with patients to say they are referring into a secondary care clinician, but there are a number of options that might happen next. They might not necessarily get a face-to-face appointment. It might be straight to diagnostic test. It might be that our clinician has a conversation with the GP about how they can be managed differently in primary care. So I think this is definitely a tool that we can use to support GPs having those conversations with patients. So we'll work on how we share it. Thank you, Richard. Shall we move on? So, as I said earlier, Stacey Burton is a former ward matron on Ashover Ward, working with us on secondment for a year in the Royal Academy of Improvement as our facilitator. She's unfortunately, she's fortunately supporting the vaccine programme today and been working really hard on that. So she's not able to be with us today to share, but we still want you to be sending her improvement ideas. She's working part-time in the vaccine programme, but she's still progressing a number of the improvements. So if you've got an improvement idea you would like to bring to life, please get in touch with us, get in touch with Stacey. What you will hopefully see as you travel around the hospital a little bit more and around our community sites as well is some posters with asking whether people have got an improvement idea or whether you've got something that you would like to make better. And you'll see on those a QR code which will take you to our Royal Academy of Improvement suggestion page. So please feel free to send us in improvements, suggestions, and Stacey or another one of us will be in touch with you to take those forwards. Royal Academy of Improvement newsletter. So hopefully some of you might have already seen this. So we've started this as a monthly newsletter to share the big improvements and the small things that have been happening across the trust. Part of that ethos of us getting much better at sharing and celebrating our success. If you've got anything that you've been working on that you'd like to see in the newsletter, please let us know. Like I said, they don't have to be huge things. The small things and are just as important. And we already know that when an improvement happens on one ward or in one area of the trust, to be able to share that and possibly implement that on a wider scale is so important, and that's what we're hoping to do through the newsletter going forward. So please let us know, and if you haven't seen those, they're on the intranet and readily available. We were hoping they'd be out there as kind of paper copies, but that's not going to happen going forward. So I think we're sharing via as many forum as we can. Just in terms of our improvement training programs going forwards. Some of you will be familiar with the CUSA training program. We have got that up and running at the minute, but we're a little bit challenged with the escalation of COVID at the minute. So we'll get that back fully on track as soon as we possibly can. But what we are doing going forwards is we've changed our one-day introduction to improvement workshop. So from later this month, that will be fully virtual. So we won't have the restrictions that we've got in terms of the Innovation Centre of only being able to have a very small number of people in the room. So Stacey and a number of others will be supporting this workshop. The idea is that you come in with an improvement and we take you through in a day how to develop your aim, how to understand who your stakeholders will be, what your measures will be, and we'll support you through that first workshop and then going forwards in terms of bringing your idea to life. The team session's about 3 to 4 hours, and like I say, if we're looking for is a frustration or a problem, an improvement that you would like to see. What we've also been thinking about with that workshop is we're very aware that there are people who really want to get involved with improvement who might not have an improvement in their area. So we can connect you with things as well. So don't worry necessarily if you don't have something. Please still get in touch with us and we'll have a chat with you about how we can link you with some improvement work. The dates are there going forward, so please just get in touch and we'll talk to you a little bit more about the content and linking you with an improvement idea. So just we end every improvement forum with sharing and celebrating our success, something that we historically haven't been great at and we want to get better at for the future. So congratulations to Ridgeway Ward, who achieved a bronze on their ward accreditation assessment this month. Our Macmillan Lead Cancer Nurse Cherie Hall was nominated by her colleagues and received a Derbyshire Royal College of Nursing award for her work in the last year, so congratulations to Cherie. Improvement efforts across the trust, so Stacey was involved in this, the health and safety team have been involved and the ward teams involved with getting recycling in place on both Eastwood and Durham wards, so it's a big win there. Similarly, Carol and Kelly, part of our brilliant Nursing at Night team, have been nominated for Royal College of Nursing Awards for their work during the pandemic. They were surprised with their awards. They weren't expecting that to be why they were brought together, but congratulations to both those, definitely very well deserved. We talked last month about our Patient Hub project being nominated for a Healthcare IT award, and I'm very happy to say we did win that award. So congratulations to Amy and to everyone involved with the Netcall Patient Hub project. You'll have seen that we've installed new seating in the front entrance to accommodate people more comfortably and safely, but the much better added privacy at the front of the hospital as well for our patients. Sodexo, our catering supplier, has retained their IAP, and the report specifically mentions showcasing exceptional teamwork and best practice at the trust. We welcomed 3 new members to our chaplaincy team last month, so that enables us to support a formal on-call service 7 days a week, 365 days a year, which is a great step forwards. We've talked previously in the forum about the brilliant work our small research team have kind of been doing over the summer, and they're going to be formally rewarded with a Chief Nursing Officer Silver Award that will come from the Chief Nursing Officer Ruth May. And finally, I just wanted to add in, on top of the really challenging day job, through a fantastic whole team, whole hospital effort, we've rolled out lateral flow testing, and we're part of the first historic steps rolling out the COVID-19 vaccine programme on top of the challenging day job. So that was a brilliant team effort, and thank you to all that got involved with that. Thank you. That was, if you have an improvement or a success story that you want to share in those slides going forwards, please get in touch and we will add them. Thank you very much for taking the time to join us. If you have an improvement idea or you want support with your improvement, please get in touch with us, and we hope to see you again next month. Thank you for joining us.
Thank you.